Thanks for tuning in to an Academy of International Mobile Healthcare Integration webinar. Today's topic is how much funding do you need? Estimating your costs and other considerations for public funding. This session is being presented in partnership with the American Ambulance Association and the National Association of EMTs. To ask questions, please use the Q&A function in Zoom, represented by the double dialog bubble button. The chat function will be disabled for participants. This webinar is being recorded and will be available for on-demand playback on the AIMHI website tomorrow. The slide deck PDF was included in your email reminder today and will be posted to the chat shortly. With that, I'd like to invite AIMHI President Chip Decker to please share with us some information about the Academy of International Mobile Healthcare Integration.
Thank you, Amanda. The Academy of International Mobile Healthcare Integration is organized for the primary purpose of promoting excellence in quality and high performance EMS and EMS-based mobile integrated healthcare. We share data, we do benchmarking surveys, we even do the occasional webinar. And it's all about sharing the data and learning from each other. If you think that you or your organization could benefit from this, please reach out to us. All right, thank you.
All right, thank you, Chip. Hi, everybody. I'm Matt, and along with Jonathan, we're going to walk you through some information about how to estimate your costs and how to ask for the right appropriate amount of funding to sustain your organization. I'm going to try and keep it relatively light. It's data heavy, as you can probably imagine that Jonathan and I tend to live in the data realm, but we are going to try and keep it light. And then, most importantly, Chip and Linda are going to give you some real on-the-ground experience with seeking public funding, talking about things like essential service, what it's like to be subsidized, what are the good and the bad and the ugly about that as well. But before we go any further, I just want to, again, compliment Amanda. She's been doing these webinars with us for a very long time, and it never ceases to amaze me how she can say double bubble button or whatever it is with a straight face and never makes a mistake when she says it, because many of us would really struggle if we had to do that. But so for many of us, we know that EMS is in an economic and service delivery crisis. It is not a surprise. These are some examples of the media stories that have been published over the last year and a half or so. In fact, thanks to Rob Lawrence and a number of folks, we're actually tracking very closely the number of media stories, both local and national, regarding emergency medical services. And since January 1st, there have been 454 of these articles cited and found and put into this log that we're tracking. And as you can see, staffing is the #1 discussion in the media. And many of us will tell you that staffing ties directly to economics, because if you can't pay people what they think they're worth, they're not going to work for you. They're going to work for Amazon or work for somebody else. And again, about 67 of those articles, or 15%, are specifically related to the economic challenges. However, what we've seen, and one of the reasons for this webinar, Jonathan and I and others are on a committee for the National Association of Emergency Medical Technicians called the EMS Economics Committee. And several of the representatives on that committee at our last meeting were commenting that they were getting questions from their constituents in their different associations or their regions, where they're being asked by local governments, state governments, okay, we may be willing to give you funding. How much funding do you need? And it was from that committee meeting that we quickly put together this discussion. And part of that you're beginning to see also in the media with states like Indiana, Pennsylvania, Maryland, and West Virginia, just to highlight a few, actually agreeing that, hey, we've heard you, we know this is an issue, we're willing to pony up some dollars. How much do you need? And how would you like that? Now, interestingly, we think there may be a reason for this, and that is something that was published recently in Governing Magazine, which is the trade journal of the National Conference of State Legislatures, I believe. Melissa Trumbull will probably correct me on that, but basically what they have found is that many governments, state and local, have not been able to spend the money that they've gotten through ARPA and even CARES Act funding. So they are looking for things to fund because they have a requirement to spend this money in certain ways. And that may be driving part of the reason for states and others being willing, and local governments being willing to throw some money at EMS. Now, what Jonathan and I are going to remind you and counsel you on throughout the next 20 minutes or 30 minutes or so is do not be shy when asking for money. This is not a time to ask for an ambulance or two. This is not a time to ask for renovations to a station. This is not a time to ask for purchasing of capital equipment, although those are nice. We're talking about establishing the right funding mechanism to fuel the service delivery level that your community asks you to provide. And it's not going to be just ambulances or capital. It's going to be ongoing sustaining funding because 75 to 80% of all of our budgets are personnel. And you can't expect a 1 or 2 year funding mechanism to be sustainable for personnel costs. So don't use the Band-Aid approach. Don't ask for a few pennies. Open that spigot, shoot high, and be realistic with the money that you're going to be asking for. Now, Jonathan, we talk about sources of funding. In short term, we talked about grants, capital purchasers, volunteer agencies do fundraisers, those other one-time allocations. But I think we're talking about more long-term solutions. And Jonathan, you are literally today in the middle of a discussion with some of your local stakeholders on this very issue. What are some of the conversations that you're having with your local stakeholders about this type of issue?
Yeah, so this is actually with an agency outside of our region that I'm working with, but it really comes down to, one, COVID, drained the water around the iceberg in terms of fragility of EMS, right? And we've been ringing this bell for quite some time now, way before COVID. But obviously during COVID, it made things worse and aggravated things. But more importantly, it actually helped people fully see and appreciate the value that we bring. And that we're not just an essential service, we're also a public good. And so what we're seeing happening, not just in this community that I'm visiting, but also many other communities and talking with my constituents and stuff, is we are seeing actually communities stepping up and saying, okay, EMS, what do you need in order to survive long term? And not just survive, but thrive. And so if there's ever been a time, now is the time, because it's still fresh in everyone's mind. There are short-term funds available for short-term fixes, and you can have a conversation around using those to get things started. But the conversation needs to be longer in term. And ultimately, and Matt's going to go over some of this, we don't just want to look at what's your current expenses and what's your shortfall and so on. What would it take if you really were able to pay living wages? You're able to pay good benefits. You've got the equipment and the medications and everything that you need. What does that look like? So it's not just what you have now. And, we've been beating this drum in the cost report issues now for the longest time with the feds is, yeah, it's going to show you what our costs are now, but our costs have been suppressed for the longest time because of how we get reimbursed. So you need to show fully, what your cost should be when you're paying living wages, when you're paying great benefits, when you've got all the equipment and everything that you need. Then go to your representatives and lay that out. Now, you might not be able to do it all in one shot, and that's okay, but you can incrementally get there, right? But ultimately, if you want to, make sure you've got the staffing for the long term, we have this kind of narrow opportunity to really, outside of normal funding that we've been basically doing the same thing for 20 years and expecting different results on when it comes to reimbursement from the government. This is a short-term opportunity to take advantage of the local goodwill you've created in your community and actually get the community to step up and pay.
Great, John, thank you. And I took a specific note about your comment regarding our costs have been artificially suppressed because of our low reimbursement. That if you guys on the webinar take nothing home from this webinar, you can sign out. That message is so powerful. And I think it related to me and others that, hey, we need to mention this to RAND. We need to mention it to CMS. We're doing this cost report process because our costs for the time period that they're going to be analyzing this were artificially suppressed. And we need to continually have or start to have that conversation. Jonathan, great point. Long-term funding, we're going to talk a little bit about reimbursement increases, not rate increases. And we'll explain why those two are significantly different here in just a moment for Medicare, Medicaid, your commercial insurers. Then obviously tax subsidy, whether it be property tax or sales tax, those are the long term. When we talk about Medicaid reimbursement change, Medicaid is sometimes easier to change the reimbursement rate because it's state driven, not federally driven, and not shareholder driven. Although you could say the legislators may be shareholders, but many states in the last year have taken this bull by the horns and said, you're right, Medicaid has been low under reimbursing for years. It's time to step up, and maybe we can use some of the federal funding that we're getting to help cover some of the costs of increasing the fees that we're paying for ambulance service. Maine is the example that we put into the slide just in the end of 2021. They passed a pay parity law so that the Medicaid reimbursement must be the same as the Medicare reimbursement. So those are examples, and again, this will be in the slide deck for you, that you may want to go to your local state legislators, and Michigan just did this recently. Other states are doing it to really get that pay parity. NAEMT is doing a lot of work with their state advocacy network on this particular issue. So it is something that you might want to really start thinking about. So expense analysis.
Matt, on that. Hey, Matt, real quick on that issue. One of the things you also need to make sure is we're seeing regulatory changes without funding. So they're talking the talk, but they're not necessarily walking the walk yet. So you need to make sure, just because something gets put into law, if it doesn't get funded, it's not going to happen. So you've got to make sure that you're not getting smoke screened or, bait and switch here. You need to make sure you get the regulation change and then just as quick get it funded. So thanks.
That's a great point. And I think, and maybe folks that are on here from Michigan during the Q&A and the panel discussion can comment. I think that's exactly what happened in Michigan, is they had that law passed that, had to be pay parity. They got a significant increase anyway in their Medicaid reimbursement, but they forgot to allocate the funds for it. So it became a bit of an issue. So Jonathan is spot on when he mentions that. So we're going to walk you through sort of this expense analysis, determining how much it's costing you to provide services. Again, this is a template that Amanda is going to provide for you at the asking, whether or not you actually attended the webinar, right, Amanda? We talked about that in the pre-session. But here's sort of the basic expense analysis. So let's say this is quote unquote Anytown, USA, and they've got a population of, what did we say here, 40,000 people. They staff ambulances 24/7. They've got 2,000 calls a year, 1,400 transports. The unit hour utilization, which is an easy calculation, 1.6. So that's a pretty reasonable, some would say low, unit hour utilization, but the cost of readiness is something that has to be incorporated into this. So if to deliver the service that you are expected to deliver in your community, your readiness cost means that you have a lower unit hour utilization, that's fine. You just have to understand it and be able to explain it to people when you're talking about funding. So from the basic analysis, let's say they've got an FTE cost of $80,000 all in. Salaries, wages, pensions, benefits, uniforms, all that kind of stuff. So that's a $560,000 personnel cost. Again, these are just rough estimates, and you can put your actual numbers in here if you want to when you get the template. The cost of an ambulance, $250K. You can decide, are we using transits, are we using internationals, whatever the case might be, put in your cost of the ambulance, then the cost to equip the ambulance, right? Because now monitors and power loads, and now the Power Load Pro, which we just got a whole bunch delivered here yesterday. Those are expensive items. So you got to put the total cost of the ambulance being available to be used for service into that mix. Typically, an ambulance will have a useful life of about 5 years. Some would say more or less, depending on how often that ambulance is being utilized, et cetera. If you can't get the ambulance replaced, you might have to consider longer, but 5 years is generally not a bad estimate. Then you've got maintenance, fuel, supplies. So you put all those things into the mix. So your total annual cost per unit is $700,000, $689,750. You then divide that by your number of unit hours. So in this case, they're staffing 8,760. So you get your cost per unit hour. Number of responses, just divide that number into your responses. That gets to your response cost. And then for transports, which again are going to be a little bit lower because we don't transport everybody to the hospital, just take the total cost divided by the number of transports that you do. And that'll give you the baseline for your cost of service delivery. But that's only one side of the equation. I'm going to pause there for a second. John, did you have anything that you wanted to add about the cost discussion, or was that pretty much it?
No, I think you covered it. Ultimately, just like you use GPS to get to a call, setting up your financials and your chart of accounts to be your financial GPS is really, really important. And it's something that I know I've seen over the years that a lot of EMS leaders don't necessarily fully appreciate, or the agency doesn't have, the ability to bring in an accountant or, some of the more sophisticated systems. But it's extremely important that you understand and you put the right systems in place to understand your expenses as well as your revenue. So if you're outsourcing your billing or you're insourcing your billing, really understanding some of that, and I imagine we'll get into that in a minute, but revenue cycle management is more than billing. All billing is putting codes on paper and sending it off for reimbursement. Revenue cycle management has to do with understanding what your payers are doing, understanding the cash that's coming in, understanding, the write-offs that you have, understanding, the discounts that are going out, and if you have a subscription program, its impact. There's a lot of different things you have to, that can get very complicated very quickly. And it's important that you understand these things, because you're going to get the questions like, are you guys collecting every penny you can be collecting? Well, you got to be able to answer that question, right? And also, what are you spending here? Are you spending more than you should be? Because now we're talking about the potential of tax dollars, and you've got public accountability you have to now have in place, as well as the right structural financial systems. The minute you start touching tax dollars and community dollars, it's a little more sophisticated than when you didn't have to do that. So, and you're definitely at a different level of accountability. So it's definitely important, pay attention to the things that Matt's talking about here. He's going to talk about revenue next, but having that really good chart of accounts, where every penny is going, being able to slice and dice that different ways. Matt's going to talk about that in a few minutes, and going from there. So thanks, Matt.
Excellent. Good point, John. So here's the revenue analysis, right? So bottom line is this: you need to look at what you're charging as far as gross charges, right? So bill charges, and then what were you actually paid? And this is where you get into the conversation with some of your community leaders when it's going to happen. They say, what do you mean you're only collecting 35%? They don't understand healthcare billing. For a long time, we had one of our cities did a big audit of our books, and they say, well, your collection rate's only 31%. I said, no shit, Sherlock, this is healthcare billing. That's what happens when you've got your two largest payers underpay for the cost of the service being delivered. Amanda, you can bleep that out of the recording. I've got a little animated there for a second. I apologize. But these are the things you want to know. Are you billing the right amount based on your market and your location? And then what are you collecting by payer? Now note, this is some actual data from our system here in Fort Worth. I de-identified it so it wouldn't embarrass any of our payers, but this is the same payer. They just have different plans. You'll note that the amount that they reimburse is vastly different. So it helps, to Jonathan's point, to have that revenue cycle management to know which insurers, if you're looking at commercial payers, who's underpaying you, who's electing to pay the Medicare allowable instead of what they should be paying, which according to your state or whatever the laws in your state are, they got to be paying 80% of the usual and customary. Knowing this helps a lot. We've done this in our system. We've gone to insurers and say, hey, you're paying the Medicare rate. You need to be paying the commercial insurance rate. Thank you very much. And if not, we're going to go to the insurance commissioner and have a conversation. And that changes that analysis. But you just need to know, hey, 515 claims, we're average collecting $644 a claim. Medicare, this is pretty typical, Medicare allowable. But again, are the managed Medicares, all of those things being reasonable with how they're paying for you? These are the conversations, the things that you're going to need to know when you go to your city manager, county administrator, or your state government to say, this is why we're losing money. This is why we need public funding, and it explains all of that for them. To put it into a more global picture, so let's say that you build $1,500 per ambulance trip, and there are some people in this webinar who are saying, holy crap, $1,500, that's crazy. No, it's not, because I would argue that if you look at your collection rate, in order to collect close to what it's costing you to provide the service, you probably need to bill that in order to get your commercial insurance rate reimbursement up high enough to cover the under reimbursement from Medicare, Medicaid, and obviously your private pay patients who don't pay squat, quite frankly, because they don't have to. But again, you billed 2.1 million, you collected 624,000. So collection rate of 29%, 30%, you'll hear people say, well, you got to take out the contractuals, you got to take out the things that you don't expect to collect. We don't do that analysis. All we care about is how much did we bill, how much of that bill did we collect, because that is a very transparent and easily explained number to your local elected officials and to your city managers. Because, and you can say, this is because, you know, commercial insurance is only paying about 50% of our total payer mix, but they're paying 70% of the bill and not paying 100%. Medicare and Medicaid are paying 25 and 20% respectively. So this is a type of analysis, to Jonathan's point earlier, this is revenue cycle management as opposed to just cost accounting or revenue accounting. Makes a big difference. So if we put those two things together, you will see that.
Hey, Matt,
Yes,
real
go
quick.
ahead.
Hey, Matt, real quick. Jump back real quick to that slide. I just want to point out something that people need to understand too. So you'll notice when he's got, you know, when we talk, there's payer mix and then there's revenue mix, right? And you'll see here where it says percent of billed, you know, you notice you see like 21% of billed insurance is what he bills, but it's 50% of his cash, or 50% of what he collected, right? So I think it's important to understand. And then you look at, let's look at, you know, the government payers. You know, they're not as bad, but then when you go down to the private pay, you know, that's represented, you know, 43% of what you're trying to bill, but only 14% of the money that you can get in. So you make sure that people understand that distinction, because they're very important and you have to look at them very separately.
Right. So on a $1,500 bill at a 10% collection rate, you're collecting an average of $150 for that transport. And it may have cost you in any town's USA's analysis here, their cost per transport is $445, but they're only collecting $150 from the private pay patients. And again, these are the types of analysis that you need to have available when you're going to tell people, hey, we need $1 million, $2 million, $5 million a year, whatever it is. We'll get into that service level in a minute. But you'll note that using those analysis, any town USA is losing money, right? Their net retained earnings is a negative number. They're losing $65K a year, which is, you know, $32 per response, $46 per transport, or $7.45 per unit hour, that they're costing more than they're bringing in. Pretty straightforward. Now, let's say that you're successful in getting Medicaid, or your ask is, we want Medicaid to increase the reimbursement. Great. You're not going to change your fee. You're still going to have the same fee, because quite frankly, raising your fee generally does not equate to the same increase in reimbursement. So here was our initial example, right? But let's say that you're able to get commercial insurers, you work with the insurance commissioner, you work with Medicaid, right? And even Medicare to reimburse at a higher rate, same $1,500 bill, but they're paying more of the claim. So when you do that, you increase your collected revenue to almost $900,000. Now that changes the financial picture. And you can say to people, okay, we were here, we were losing money, but when we increase the reimbursement, either by Medicaid increasing or Medicare increasing or the insurance commissioner putting the screws, now you can operate in the black. And you can show that pretty clearly. And this again says to somebody, hey, if you agree that you're going to implement a Medicaid rate increase, we don't need any funding. So you build that into your model, and that public funding becomes the Medicaid increase, like they're doing in Maine, like they're doing in other places, because that alleviates the perhaps the burden of the local taxpayer paying that. John, any thoughts before we move on to the next thought?
No, I think absolutely, and that's a lot of conversations I'm seeing across the board, because you could be in a situation where it could be a couple of years away. So that's again where ARPA money or CARES Act money or whatever can be used to bridge you for those couple of years until that Medicaid regulation is made and funded. You know, so there is potential use of those short-term funds. And I think we're going to talk about the next piece, but also this, remember, these are the expenses of your existing operation, not necessarily, again, these are artificially depressed expenses. And so therefore, and Matt's going to talk about this next, I believe, you know, how do you then go and adjust if you truly want to raise your living wages or raise the living wages, you need to add benefits and other things like that. And then you'll see how things can change based on that. Exactly.
So, as Jonathan said, but your current state isn't your desired state. So you say, hey, so we need funding for pay increases because we're going to increase pay, or we have increased pay. You pick the number, but you just change your formulas. So now instead of an $80,000 expense per employee, you've got a $100,000 expense because you're increasing the pay. Most of these other expenses stay the same. Now you're going to have to change these and do this periodically. We do it monthly and quarterly to determine what are these expenses, our fuel expense skyrocketing, supplies expense skyrocketing, et cetera. But you can keep doing this continually once you have it built and then just show trends over time. But now that you have a much higher personnel expense, even at the higher reimbursement rate, you're still in the hole. So again, looking downstream, and I wrote it down here, artificially suppressed costs isn't the status quo. So, hey, we in order to up staff, in order to get back to 100% staffing or 90% staffing, we need to increase pay rates. It's going to cost 130,000. It's going to put us in the hole 130K. You multiply that out by the number of ambulances that you have, whatever the case might be. But this is the way that you start doing that analysis. Now, be ready, because your current service delivery level will be challenged. They will say, okay, let's say that this agency is providing a 7-minute fractile, 5-minute average response time with an all ALS ambulance fleet. Okay, that's a pretty high level of service. And they're doing that with 4 ambulances. They have a UHU of 0.136 because they have to maintain that level and perhaps in order to achieve this response time. This is their expense per unit hour, the annual expense. So their expense is way in excess of their revenue. So revenue 1.79, revenue 1.79, expense 6 million. So they're $4.2 million in subsidy or 4.2 million in the hole. What if the city manager, county administrator says, the 7-minute thing maybe isn't such a big deal to us. So maybe let's look at maybe a 9-minute fractile time with a 7-minute average. And can you calculate out for us what that would do to the need for money? To do that, you eliminate an ambulance, right? So you just cut that ambulance, lay off the personnel, reassign them, whatever. It drops your expenses by $1.5 million. That's the conversations that people are going to have. Hey, instead of a $4 million, 4.2 million, we prefer the 2.7 million. So just right size your utilization. We're okay with this response standard. And yes, it's still all ALS, but we can sell this to the community because we don't need to do a tax increase. Be ready for those conversations because they will absolutely happen. Speaking of response times real quick, the whole discussion about public expectation, be wary. People are going to want to ask, what does the public expect? They use that a lot. We've done an analysis using EMS survey team data. Thank you, Bobby Hopewell and team. And we matched all of our priority 3 non-light and siren response times, no first responders on these calls, and noticed that the patient experience scores 1 to 5, 5 being most satisfied, were pretty consistent irrespective of our response time, even when our response times were over 45 minutes on a low acuity 911 call, because the question is asked, did the ambulance arrive in a timely manner? Not were they there in 6.2 minutes, not were they there in 9 minutes. And your expectation, was your expectation met with the time that it took for the ambulance to get there? And again, for low acuity 911 calls, the twisted ankles, the cut fingers, the things that people call us for, people don't mind waiting 30 minutes for an ambulance because they know it's a low acuity call. They probably just don't have the Uber app and they need to go to the ER. And the coefficient of correlation here, there is no correlation to response time and the patient's experience score for the ambulance arriving in a timely manner. All right, next service delivery discussion is all ALS versus an ALS BLS tiered response system. Happening everywhere. We've just done it. One of the reasons for doing it was to reduce our unit hour cost. So you take, again, that same system, keep the response time the same, but drop 2 of the ambulances from an ALS ambulance to a BLS ambulance. Your expense per unit hour goes down from 172 down to 135. And you go from needing $4.2 million to $3.6 million. Little savings, not too bad. But again, you may have to have these conversations with your local leaders. Do you really need that or not? So if you do the reduced, if you do the reduced or the lengthened response time with a change in the service delivery model using a tiered deployment system, now you start talking some real savings. 2.4 million if you do one of these ambulances, it's BLS, 2 ALS ambulances, use priority dispatch to determine which calls they need to go on, and you can start having some real savings. Again, people are going to ask you this question when you start asking for more, either more money or money for the first time. Jonathan, you live and breathe this in a number of systems in your consulting practice. Is this a fairly realistic example?
It absolutely is. I would say you go in with all of this information in your hip pocket, You go in, and I wouldn't say shooting for the stars, but you go in saying, if we want to maintain the current level of service, or for some reason your level of service needs to be improved, and we want to, recruit and retain and keep, staff, we've got to adjust pay and benefits. So you go in, you ask for, what does that look like from a regional perspective? And then they are still going to start to potentially ask questions. Well, that's a lot of money. We can do this short term. How long is you're going to need this money for? That's probably one of the first questions they're going to ask. Is this a short-term issue or a long-term issue? And then you can have the discussion around, well, if the state Medicaid office would raise, rates, the Medicare rates, there's quite a possibility we wouldn't have to ask as much, or maybe we'd only need a bridge loan, until that time would happen. And then that revenue could offset our costs and we could go longer without a subsidy, maybe. But if you're trying to increase wages and do the things you want to do, there may be other trade-offs. And so their trade-offs could be, well, we don't need 5 ambulances or 6 ambulances, or we don't need that response time as Matt is suggesting, or maybe we can look at alternative tiered model, although Matt knows it's like nails on a chalkboard for me because I'm an LALS system purist. But necessity is the mother of invention and drives acceptance of the previously unacceptable. So we're seeing this across a lot of the EMS systems across the country, all the pubs. Things that were sacred cows that we've had, of all ALS are having to be slayed because, one, the clinical evidence in the medicine clearly shows that, especially in an urban environment, ALS doesn't really save lives. Quick BLS does, right? And then it's really more in the rural setting where true ALS has a true impact, right? Clinically speaking and outcome speaking. So these are some of the tougher conversations you have to have in right-sizing your system while also providing, not just the funds for your organization to pay better wages, but also make sure you figure out how to make your organization the best place to work, right? Because it's not just money that attracts people to an EMS system, it's their leadership or lack thereof, which drives people away. So those are both things that require investment. Money's not going to fix your problem if you've got a cultural issue. It may help a little bit, but it's not going to solve that problem.
Excellent point, John. All right, so just a couple of highlights before we get to Linda and Chip, because they've got some real insights into all of this. Other sources of funding, property taxes. Obviously, if you're going to get public subsidy, the biggest part of that tends to come from property taxes. Just beware of tax caps. So a lot of states are putting in these millage caps that local communities cannot exceed. That's a huge taxpayer voter initiative. Sales tax work really well to some extent, and you can actually get some dedicated funding. A lot of agencies have been successful in doing that. You get a half-cent sales tax or others. Police departments have been doing this for a long time in a community crime prevention, crime control prevention district, CCPD. That's funded primarily from a sales tax increment. So those are the things that you can do. GEMT, there's been a lot of discussion about that. Many states have GEMT. The problem with GEMT historically is it's only for public agencies because it is a taxpayer offset because of Medicaid's underpayment, if you will. Forever, those have been cost-based, and in many states, those are still cost-based. So the higher your cost, the higher your GEMT reimbursement, which seems to make no sense. We didn't think that made any sense in Texas, and we were able to convince the Medicaid commissioner to flip that model. And it's no longer cost-based. It's now a difference between the average commercial reimbursement and the average Medicaid payment. And that was specifically done to stop incentivizing inefficiency and high costs. Medicare loved this state plan amendment when it was filed, approved it like the next day. So beware in those communities where you're having cost-based GEMT reimbursement, those days may be numbered because the payers are looking for a much more reasonable way to offset the price difference between, or the revenue difference between Medicaid and your average commercial reimbursement. Provider assessments is sort of the tax-like system where every provider puts money into a pot. That money is used to leverage some federal dollars to come back to the state. And then that money is reallocated back to the providers based on their percentage or their number of Medicaid reimbursements. If you'd like more information on this, Public Consulting Group, which is a great partner of NAEMT and others, really does a good job with this. They've gotten GEMT legislation done and provider assessment legislation done in a number of states, and they really are the experts. So we'll maybe bring them on. I think they've done a couple webinars for NAEMT already. Those are sometimes hard to pass in red states because they view it as a tax and they don't want taxes, but they've been pretty successful in some of the states that have been able to get it done. Jonathan, any thoughts on that concept before we turn the floor over to you to talk to our panelists?
No, I think you covered that stuff pretty well, Matt. So.
Okay. John, you want to talk to, or maybe let Linda and Chip introduce themselves, and then you can start firing these questions at them.
Yeah, Linda, you want to introduce yourself first?
My name is Linda Frederiksen. I'm the Executive Director of Medic EMS. We're a service that's based in Davenport, Iowa.
Thanks, and you're a public utility model, right?
Correct.
Or I guess a reformed public utility model, as I would say, because you also now do the operations as well as the authority work, correct?
Yes, that's correct.
Yeah, thanks. And Chip, could you introduce yourself as well?
Sure, thanks, Jonathan. Chip Decker, CEO of Richmond Ambulance Authority, and we are also a modified public utility model. We were self-run since about 2007, when we went from 30 people who did billing and managed a performance-based contract to 300 people who ran the system. So, and we are located in Richmond, Virginia.
Thanks. Thanks. And to note, both Chip's organization and Linda's organization are members of AIMHI. And one of the value propositions of AIMHI is really helping each other through some challenging times and learning from each other, right? And sharing different ideas and thoughts. And Chip, I mean, you probably were one of the first pums to go get subsidized, right? So why don't we rewind the clock, because it's kind of a tale of two different cities here, with the Richmond Ambulance Authority and where you are currently versus where Linda's organization and Medic is out in Davenport. Chip, why don't you rewind the clock, and maybe, I think you were there during that day, right, when you guys went first for a subsidy, and then how did that go? What were the things that surprised you? Whether some insights or value you could provide to the audience in terms of that process?
So the Richmond Ambulance Authority has always had a subsidy from the city. Being in Virginia, we're a Dillon Rule state, and so my enabling legislation allows me to do 911 within the city, which is 62.5 square miles, and non-emergency of the pre-scheduled transports within the Commonwealth. And because of our payer mix and whatnot, we just don't generate enough revenue. We have a lot of unhoused people. We have the non-residents that we have to also take care of, and some of the other challenges that come along being a capital city. So over the years, we've always asked for a subsidy, and for the most part, the subsidy was granted. Here recently, with fiscal pressures on the locality, they haven't been able to do that. And so one of the things I had to do was get creative with what the ask was, prove why I needed the ask, and figure out, all right, is there an opportunity for the city and the ambulance authority to come together and to provide and compete in the current marketplace? And so I can certainly tell you some of the things that I did right and the things that I did wrong when I went to the city council, city administration to say, oops, yeah, I need more money. And as Jonathan mentioned earlier, you have to make the proper ask the first time, and I failed to do that. I made an ask of, let's say, all right, I need $6 million, when I really needed more. And because I was, do you want to just get by? No, because the competition has proven itself to be much fiercer in the for employees than ever anticipated. So I had to go back and make an additional ask. All right, so, and then that obviously brought up the, what are you talking about? So so a couple of things that I learned. One, it's whenever you go to a meeting, particularly with politicians and whatnot, that you don't use abbreviations. I mean, I've been doing this since EMS since I was 15 years old, and whether it's my people speaking or when I'm speaking, you can't use the abbreviations that we use. You know, so people don't know the difference between an EMT and a paramedic, and may not even know what an EMT is, other than they've heard it before. So have your experts in the room. Take your finance person, take your HR person if you're talking about you know, turnover rates and things like that, because they will ask about that. That is on every politician's mind right now is, all right, what's your turnover rate? Because everybody's saying we're short of people. So take your experts in the room, because so often, put your experts in the room, because so often they'll ask a question and you don't want to say, oh, I'll have to get back with you. Figure out how many votes you need. Count the votes. When it comes down to all in favor, you need to be on the prevailing side if you want to get the votes. What somebody told me early on was find your advocates, find your cheerleaders, and they include some of your politicians, your community influencers or activists, clergy, because they can speak for you, and big business. If you have, you know, say, to basically come out and say, yeah, this is an essential service and it needs to be funded. So we put together all the people. Now, my big takeaway here is the information you present has to be accurate and consistent over your whole narrative. And where you can get tripped up is, all right, if you start with these numbers and then you get updated numbers and you present now updated numbers, it confuses people. You have to stop and pick a moment in time and bring that moment forward. Because there are people, whether it's the media, whether it's other people sitting in the room, whether it's, you know, other departments that are looking for you to be inconsistent. And so, yes, that is absolutely critical, whether you're talking to the media or talking to your politicians, because, you know, in the room with me when I'm speaking, I put my PIO. And so long as he doesn't have to stand up and say what the CEO really meant to say was, you know, then I'm doing pretty good. But make sure your information is accurate, and it's got to be the same throughout the course of your narrative. And we have a lot of uncompensated services here. I mentioned that a little bit about the non-resident responses or the unhoused folks. But we also are required to do community events, standbys for severe weather. We had a bout of protests here in the city. And so all of that needs to get factored into, you know, our uncompensated services that we provide. And one of the things that I kept getting asked is, so if you have, we would use predictive data, say, if we don't get this, this is what it will look like. This is what we will have to cut out. You know, whether it's going to be response times will get longer, or whether or not I'm not going to be able to respond to the public assist calls, whatever the case is, or I'm not going to be able to do these, you know, community events. But if you're going to say it, if you're going to make the threat, it needs to be real, and you need to do it. You can't make, you know, say, oh, it's going to be gloom and doom, and then they say no, and then business continues, you know, as usual. And it also keeps you from making an idle threat.
Hey, Chip, it sounds, everything, all the advice you've given us is great. We just want to keep an eye on time, so Linda has a little bit of time as well, and then we can cycle back if there's other messages. But I think the key takeaway there is, and this is what I've noticed too, is the business happens behind the curtains. The political theater happens in front. right? And you need to understand that you don't want to be doing business in the political theater. You want to do the business behind the scenes. You want to get these questions answered, pre-answered, understood, all those kinds of things, because the last place you want this to potentially an error to be found or an inconsistency to be found is in the front end of the public theater, right? You've got to make sure in the back end there's confidence and that you've done your due diligence and your work together. Linda, you're in a different situation, right? You're in the process of trying to gain a subsidy and also switch some things around for your organization. Why don't you go ahead and share with us in a few minutes how things are going and some of your challenges that you're having?
Sure. So we have a little bit different scenario. We're based in Davenport, Iowa. We cover about 450 square miles for primary 911 responsibility. So obviously we're in Iowa. We do have a metro area where we have some significant population density, but we also have some, many rural square miles. So we have about 165 employees. We're down about 18.5%, which is very significant for us. I feel fortunate to be only down that far and are in the process of rebuilding that staff. But as everybody said, staffing is definitely the name of the game right now. We noticed that with the Affordable Care Act that we started to see that payer mixes were starting to shift. So Medicare for us has always run right about 50%. But we noticed that it became easier to become a Medicaid recipient. So our 15% of Medicaid went to about 30%, and unfortunately, commercial insurance for us went from about 30% down to 15%. So that was kind of a concern for us because obviously we were getting much less revenue. In addition to the fact that Medicaid in the state of Iowa is reimbursed at the lowest. We're in the last 5 in the country for reimbursement. So we started to see our revenue per transport start to drift to and slightly below our cost per transport. Actually back in about 2015, looked at our current status as a 501c3 and started to look to see if we could look at something like a 28E model, which in our state is one or two government or more than 2 government entities. Let me say that again, 2 or more government entities that group together to become a governmental provider and to receive governmental benefits. As a 501c3, we're not able to get all of the benefits that governmental providers get. A couple of examples, sales tax. We have to pay sales tax even as a 501c3 here. Some don't, but the way we're incorporated, we do. The other thing I'd like to note is the fact that about 70% of the ambulance transport providers in the state of Iowa are 501c3s, and most of them are volunteers. And again, as we continue to see the staffing crisis march forward, we're seeing many of our providers in our state age out. We're seeing many people that are well into their 70s continue to volunteer on their agencies because of staffing shortages. So during our process of looking to see if we could reincorporate as a 28E model, we found that our state in 2018 passed GEMT, and the funds for GEMT started to flow for governmental providers in 2019. So that further fueled our interest in that. 28E, the other additional things we could look at is we could look at recruitment and retention of staff. We have a great defined contribution retirement program for our employees, but a defined benefit program, and in our state it's called IPERS, the Iowa Public Employment Retirement System, which is a very solid system, is very attractive to people in terms of retention and also in terms for recruitment. The other thing is don't forget to engage your legislators. Chip has been talking about, find your champions out there, but you really want to make sure that you're letting your legislators know that, here we're sitting in Iowa, a state with a surplus, but we're among the last 5 in the nation for Medicaid reimbursement. So our state was able to pass some legislation in the last year called Chapter 422D. It does give us a little bit of a glimmer of hope where it could give a county maybe a bucket of EMS funding. And basically what happens for that is you essentially have to put that to a vote of the people, and it has to pass by 60%. And what that would offer is it would offer a revenue opportunity through 75 cents upon $1,000 of tax valuation for property in the county, and it also would offer a potential for some income tax taxing, so just dependent. You would have to declare EMS as an essential service in your county to get that funding to go through, and that would only last for about 10 years. So you would have to put that to the vote of the people every 10 years. And how many people out there right now are voting for a property tax increase? Not too many right now. So of our 99 counties in Iowa, and this is very, very new legislation, we have many who are getting ready to put that to a vote, and we have 2 of the 99 counties who have successfully voted that in and have systems that are benefiting from Chapter 422D funding. And that's really about all I had. We're just continuing to go through that process. I know that as you get your communities of interest, you know, you kind of win one hill, and then as you're trying to win another hill and to tell them about the benefits of this funding, you lose the other hill. So it's trying to get everybody on the same page at the same time.
Great, thanks, Linda. I know we have a couple of questions we want to get answered, but I know, Chip, you wanted to give maybe a quick summary, maybe a 1 minute or less summary, because we only have a few minutes left, and I know we want to take questions and get some audience participation as well. And why don't you go ahead and maybe provide that quick bullet list of lessons learned?
Sure. Just wanted to jump to the end and let everybody know what we ended up working out with the city for the subsidy. They weren't able to give me the full subsidy that I asked for, but we were able to come up with a sort of an interesting way to do it, is that they have more leeway in purchasing capital than giving us actual dollars. So what they agreed to do was purchase the ambulances we were going to purchase for 2 years, and we would repurpose the money that we were going to use out of the authority budget to basically to personnel, and because the city can fund capital purchases, you know, with bonds and whatnot. So that's what we ended up doing, and we're just going to lease them back from the city for the use of the ambulance authority. So, and we're still working through that, but that's where it's headed.
That's great, and it's great advice, because the subsidies can come in other forms, right? You can get offsets for fuel. You know, especially if the city or the community has, you know, governmental fuel depots, things like that, where you can potentially get subsidies, especially given the cost of fuel. I've seen buildings, you know, and access to, you know, free leases or dollar leases for buildings. There's all kinds of other interesting, you know, mechanisms out there that can be more indirect than direct funding. You know, going down a road and kind of thinking out of the box and looking at other ways to achieve the same goal makes a lot of sense. Linda, thank you too. I mean, I know that you guys are working on and got an amazing organization there, and you know, you continue to struggle through some of this. It's been a couple of years now, so thank you for sharing. You know, somebody did bring up, and I think there's 2 things that, in looking at some of the questions, I want to try to quickly address before I maybe hand it back over and see if there's other discussion. One is, how do you account for, one of the questions is for volunteer labor, and right, that's a great question. Because you don't want to put 0, or right, because that's going to get us all in all kinds of challenges. And then, quite honestly, in some states who were doing cost reporting, especially looking for maybe that Medicaid gap funding, because you know, the not fully appreciating the impact of the answers to some of these cost reports, artificially deflated even more, you know, the cost. And so it's very important that you account for volunteer labor. I think the best way to do it is, hopefully you're keeping track of all the volunteer hours in your organization, which most volunteer organizations do, and then take that number and figure out what's the prevailing wage for an EMT and a paramedic. And if you have your manpower hours split between those, then you can do a quick calculation to understand, okay, all of these volunteer hours actually equal this amount of expense, right? Based on the market value of a paramedic or an EMT. So definitely one way. And if you're not accounting for your volunteer hours, you definitely want to try make sure you're doing that. One of the other things that came up is just because you're designated as an essential service doesn't mean you're going to get money. And just like we talked about on the Medicaid side, just because they put a Medicaid regulation in that says they're going to pay Medicare rates, if it's not funded, you're not going to get the results. Same thing on the essential service side. There are states who have designated EMS as essential service, however, not funded it, right? Or not put their money where their mouth is. So you're getting sometimes political wins just, again, for political theater or votes versus actually getting the teeth sunk into fixing the problem. So I think it's just something that I noticed that I would pick out in terms of questions and answers. And Matt, maybe I'll hand it back over to you and tie things up or more questions.
Thanks, John. I want to make one comment and then answer one of the questions. The comment about essential service, where I think a lot of people have perhaps a misunderstanding, is they compare the essential service designation to police and fire. Many states have a requirement that local counties or local communities must provide for law enforcement, fire protection. That always comes with a cost. So that has been like that in many cases for a very long time. So the fact that a city, a county, a community needs to pay for police protection is accepted. And quite frankly, the police department doesn't get a lot of Medicare revenue and a lot of commercial insurance revenue and all that sort of stuff. And the same is true for the most part for fire service, non-EMS fire service. So the fire departments and the police departments have limited revenue opportunities other than public funding. In EMS, we are a vital public service. Some would say, including myself, an essential public service, but we're unique from police and fire in that insurance companies pay us for the service that we provide to their insureds. In the fire department, police department service delivery model, generally that's not true. So people have accepted the fact that a portion of their tax dollar goes for law enforcement. They expect that a portion of their tax dollar goes to fire protection. Getting them over the hurdle of the fact that your insurance company is not reimbursing the cost of providing service. Therefore, if you want an ambulance at your house in 9 minutes with 90% reliability, you need to pay for that with your tax dollars because your insurance company is not paying for that. The other thing that we hear often, everybody has the need to get police protection. Police protection, fire protection covers every person in the community. Therefore, everybody should pay for it. EMS services only people who crash, shoot themselves, have a heart attack, whatever. So some people say the people who use the service should pay for it. And I would argue, and I have in some legislative committees, try that model with law enforcement. Try that model with fire protection. So the homeowner pays the fire department for the cost of putting out the fire. How does that go? The community member pays for the police response to their burglar alarm or to their whatever it is. That model is tough to sell. Anyway, so just keep that in the back of your minds. There was a question specifically about the Texas change, and I want to answer this because I think it's something that's going to happen a lot across a number of states. For years, Texas's ground emergency medical transport program, which offset the cost of public agencies providing EMS, would allocate tens of millions of dollars to public fire departments, Dallas, San Antonio, Houston, other departments that were doing similar call volumes to what our call volume was, and they were getting GEMT payments 10, 15, 20 million dollars. And public agencies like Williamson County EMS or hospital districts or MedStar governmental entity were getting 900,000, 1.2 million. And we asked about that. Why is it with a similar response volume, similar call volume, similar Medicaid demographic, why are the fire departments getting so much more than these other agencies who are also public? And the response from Medicaid was because their cost is so much higher. The cost, and I won't call out anybody, but the cost of ABC Fire Department per transport is $2,800. and MedStar's cost per transport is $396. And it's a cost-based reimbursement program. So we made the argument that, so basically you're rewarding inefficiency. You're subsidizing agencies that choose to operate at a high cost. And is that fair? Why should we be penalized? You're paying us the same amount that you're paying these other agencies for the Medicaid reimbursement. So, and they bit. They said, you know, you're right. That really doesn't make a lot of sense. So they asked for another model, and we suggested that it should be the difference between what an average commercial payer pays for emergency ambulance service and what Medicaid is paying. And that delta, depending on your agency, could be $1,000. Because if we're billing $1,500 and the commercials are paying 80% of UCR and we're getting reimbursed $1,200, then that's a big delta. And we're writing off the difference to bad debt. And Medicaid said, that seems like a much better model. And then some agencies said, well, that's not fair because we underbill. We only charge $600, even though it costs us $2,800, because that's just our city council's policy, because they don't want people to call and complain about the ambulance bill. And this is a little bit too under the tent, but I'll share with you this conference call last year where this conversation was being held between the Medicaid commissioner and a number of the large public fire departments. And the Medicaid commissioner, upon hearing that claim, that's not fair because we bill lower, blah, blah, blah. The Medicaid commissioners at the time said, bad public policy on your part is not my problem. If you're not charging what insurance companies are willing to pay and you're relying on the state to cover, or the local taxpayer to cover that cost, that's bad public policy. So they switched it. They switched it to an average commercial, the difference between the average commercial reimbursement and what the average Medicaid reimbursement is. And based on CMS's response to approving that state plan amendment, I think that there's going to be a suggestion that every state change their GEMT to that model. Sorry, little soapbox there. Jonathan, did you see any other questions in that we should ask or answer, I should say?
I think Jamie had asked for some additional assistance on making the argument of an essential service for EMS. And then again, more importantly, getting it funded. So a couple of things I'll definitely ask others to chime in too. First off, remember guys, we wear 4 different hats. We have a public safety hat, we have a public health hat, we have a disaster response and mitigation hat, and we have a healthcare hat. We get paid for one, and we get paid for one poorly. We don't get funding for the public safety aspect, which is really the cost of readiness. And when you really sit down and look at what EMS does, right? All your medical calls are really healthcare issues. All your trauma, shootings, stabbings, vehicle accidents are really more public benefit, public good kind of stuff, right? And that's really how you kind of have to frame things. And that's a public safety mission. Obviously, what we did during COVID was a public health mission if you were out doing vaccinations or swabbing. And then finally, also along with the pandemic was a disaster response situation, right? Which was more of a long-term disaster, but even think of, your more local disaster situations, mass shootings, all the things unfortunately we're having to deal with today. So I think as you're making your argument as EMS is an essential service, definitely go over what are all the things that you do in EMS? What would happen if an ambulance didn't respond? Let's go back to prior to 1960, and either there was no ambulance or the hearse responded. A lot of people say if we don't get things fixed, we're going to come full circle and it's going to be the hearses that are responding to pick up, people. And you got to be careful. You don't want to use the emotion too much and pull that card out. Oh my God, people are going to die kind of thing. Let's be realistic about some of this. But I've also been places in developing countries where they don't have EMS and watch the other effect of that too, which is horrible, right? And so ultimately we need to have an EMS system. It needs to have good quality, good reliability. Our patients need to be satisfied. Our providers need to be engaged, happy, well paid. And again, kind of that best place to work thing. And so I think those are some of those arguments. The other thing too is, one of the things we've seen is EMS being used as a piggy bank, right? And the minute, whether that's franchise fees or other kinds of things to offset government coffers, or depending on how your revenue flows, revenue going into a general fund and then it not being all put back to EMS. These are things, there are trade-offs to some of this, right? The accountability issues we've talked about. So, but if your system is being used as a piggy bank, one of the arguments you could make the minute you start taking on public funding is, it's a left pocket, right pocket shift at this point. So there are some potential other offsets to expenses, as you go to look at this that you can potentially do. Anyone else have thoughts on, how do you make the argument to your politicians about why EMS is an essential service?
Linda, what have you used? Or what did the state use when they were passing that legislation?
In terms for the 422G?
Yep.
I mean, there was just a groundswell of many of our state legislators that worked very hard on this, and it's a glimmer right now, but it certainly is a dedicated bucket for just dedicated to EMS, which is declared an essential service. And I guess the thing I would like to say too is this is inherent on also appointing an MSAC or a local advisory council for the county. And basically that funding may not all go to the ambulance. They're looking again for the public good. So some of the funding could go to some first response agencies or other agencies that are also engaged in providing EMS.
That's a great point. Chip, Jonathan, any closing thoughts before we give folks some time back in their schedule?
No, I think, we've done I think as best as we, I think, fully appreciate from an experience base, was trying to share some of our knowledge and wisdom in this space. Hopefully you've been able to take away some good things from this. Like I said, if there's ever a time, now is the time. People unfortunately have very short memories, as do politicians. And a year from now, if COVID's gone and things start to dampen down, and we're going to miss this opportunity or this window, just like we're trying to use this opportunity to reform the payment system. This is also probably a once in a lifetime opportunity, to, as a nation, go out and make these calls, because if you, again, look at what's happening on the news, the EMS systems are failing, and you've got many communities stepping up to the plate. So you've kind of got, hopefully this mob mentality you could eventually get everybody to jump onto that bandwagon, especially if it's happening in other parts of your states or you start to compare to other EMS agencies. So now's the time to, make sure you have your ducks in a row from a financials perspective and so on. Make sure you understand your operation and what you may have to trade off in order to get this. Make sure you understand what it's going to take wage-wise, and all the things that we've talked about, and then go for it. I mean, I think, all they can say is no, but I bet you might find that there's probably some political goal right now to help you out.
Terrific. I want to thank everybody. The panelists did a great job. Thank you, Amanda, for putting all of the logistics together and getting everything squared away. I want to thank all the people that logged in. Hopefully the links are all working. I double checked and they seem to be working fine. The workbook is a direct download, so when you click on it, make sure that you've got the ability to direct download from there. Amanda will send that out as well to the participants if you want it. Certainly get it. The PowerPoint is out there. This is an important time for your agencies, for us as a profession. So I think I'm going to speak for most of the panelists, if not all. If you have questions, you have thoughts, you need some help, rising tide floats all boats. We will help you because we use examples, and it will help all of us if we do this right. So thank you all for attending. Amanda, any closing thoughts on accessing the PowerPoint, etc.?
Thank you so much, Matt. Just to reiterate what you already said, the workbook as well as a link to the slides have been posted in the chat. If you've been having any issues accessing the chat, it will also be emailed around no later than tomorrow. If you can't wait until tomorrow for a recording of this session, it was also broadcast live on Facebook. So be sure to like and follow AIMHI on Facebook, and you can launch the replay right away. Thanks again.
Bye, everybody. Stay safe, stay cool. Bye-bye.